All right, so why don't we go ahead and get rolling, and then folks will just join in as they are available. Welcome back, everybody. Hope everyone had a wonderful and very socially distanced Thanksgiving holiday. Hope everybody's doing well. I know that folks I've heard from several folks beginning to start to feel stresses with staffing issues, and obviously the onslaught of folks who are calling and should I get tested? How can I get tested? How can my child get tested? So I know that's only going to get worse. I know that there's been a few folks who have reached out with starting to feel the constraints of staffing with staff members who are out ill or staff member who are quarantined because of travel or exposure. I know there was one practice that thankfully is not part of our group, not part of AHP, but one internal medicine practice in the greater Rochester area has 10 staff members who are out, 4 that are in the hospital, and 1 that is in the ICU right now. So clearly we are starting to see some ripple effects where that practice was actually considering closing altogether because they just don't have enough staffing to be able to carry out business. So hopefully it's not going to reach that point for any of us, but clearly we are seeing some other of our comrades across the community that are experiencing that, unfortunately. We can jump into the graphics. The numbers are kind of what you would predict. We are still seeing a steady rise. I will say that some of these numbers probably belie the truth a little bit. And what I mean by that is nationally, the numbers are clearly going up at a pretty rapid rate. Remember I said before, it took us 9 days to get from 12 to 13 million. It took 6 days to get from 13 to 14 million new cases. So we're cutting that time interval pretty significantly. And the anticipation is that it's going to get even tighter here in the next few weeks. Also, as you'll see in the graphic in a moment, what the various health officials are estimating is going to be a plateau and spike phenomenon, where we're going to see a little bit of a culling of the rates and then a large exponential increase again. So over the Thanksgiving holiday, there was less people who were seeking testing, especially with schools in the local area that went into the red zone and had to test to get kids back. They weren't going through PCR testing, so we saw a little bit of diminution of the total volume of testing. But now with the post-Thanksgiving exposure and expecting that people will start mounting symptoms or learning of contact, we expect that spike in cases to follow shortly thereafter. So the warning really has been to not get overly confident if we start to see a plateau in the numbers for a few days, that we likely will see a little bit of a stair-step pattern in the numbers, maybe even for a few weeks as we see some of these holiday gatherings and group get-togethers taking hold. Locally, I'll attract everybody's attention down to that 3.5% positivity rate. So that is global testing, is my understanding for this particular number. That's for Monroe County. Yesterday, Adam Bello, the county executive, reported that the 7-day rolling average of positivity was 6.81%, which we were only at 4.75% just a few days ago. So we really are starting to see that escalation. We're averaging now a little over 500 to 540 cases a day in the Monroe County area. The hospitals in the Finger Lakes region are at about 2x the peak capacity from the first wave of COVID. The current modeling that exists anticipates that within the next 6 weeks, we will likely hit 5x of our hospital capacity during the first wave of COVID. The worst case modeling at this point anticipates it could be as high as 10x, which that could be significantly overwhelming. Even 5x is going to significantly tax our resources because hospitals are already, if you look at the fill occupancy rates, I think in the Monroe County area, if we extend that to include Thompson and Noyes, I think Unity, General, Strong, and Highland are all at or above 100% occupancy. FF Thompson is pretty close, and Noyes is about 50 to 70% occupancy at the moment. If you kind of go out another band and you look at UMMC and Clifton Springs and the others, you gain a little bit of extra capacity, but not a lot. and those are smaller institutions with fewer beds in general. So we're already starting to see the stresses locally, in a 5x capacity could be fairly significant for us, to say the least. We also, as you can see, in the Finger Lakes region, we're at 68 folks in the ICU currently. Again, I will emphasize that we have seen a higher rate of COVID patients being discharged, and being discharged more rapidly than they were in the first wave. We're also seeing the ICU patients are less likely to be ventilated on a ventilator than they were in the first wave. And their ICU length of stay is slightly less than what it was in the first wave. So all of that is good, but we may not have seen the sickest of the sick. And obviously one of the big concerns is that the younger folks who may have gone to Thanksgiving dinner may have exposed grandma and grandpa. And if those folks start showing up in the hospital, obviously that's going to be a sicker, higher trend rate towards ventilator dependence and the like. So lots going on. I think the likelihood is we are now entering that window of time where we can anticipate that the Thanksgiving exposures will start to mount symptoms. So I would say, anytime now to the end of the week is probably when we'll start to see the onslaught that Thanksgiving will bring, and it probably will even extend into next week. So we'll see what that takes us to. Obviously following closely behind with holidays and Hanukkah and Christmas. So there's going to be a lot of bumpy road ahead, to say the least. I guess we can go to the graphics just to show that. But you get a real appreciation that bottom right when we look at hospitalization. So this is actually, I shouldn't put that as Monroe County. That's really the Finger Lakes hospitalization rate. So you can see that exponential climb is continuing really unabated at the moment. The mortality rate is starting to inch up, but not nearly at the same rate. And we're certainly starting to catch that 10 to 14 day post the curve of the hospitalization going up. So now is the time. If we were going to see a commiserate response in mortality, we would start to see it. Thankfully, it is not at the same level as what we're seeing for hospitalization. And the ICU curve obviously is also going up, but also not commiserate to the rate of hospitalization incline. So that is also good. I'm not sure there's anything else to show here. The next graphic actually might be a little bit more telling. We talk about that plateau and spike. This is kind of what we're talking about. So you can see in that the new national cases, in particular, you see how it starts to ebb and plateau. The anticipation is within a couple of days, we'll see another sharp elevation in that curve if the modeling holds true. So it's just something we'll have to kind of keep an eye on as we go forward. As we look regionally from the information Nick Apostolera shares with us, so from our surrounding county areas, much the same. In fact, the mortality rate continues to be concerningly high in these regions, but the rate of positivity also remains very high. Obviously, the testing resources are more limited, hospitalization resources in the local community more limited. So, it has a bigger effect in these communities even than it does more centrally where we have more resources. Erie County still remains the leader of the pack to the western part of the state. They entered the red zone faster, although they seem to have ebbed a little bit quicker than we have. Although it's not clear yet if their ebb is just another plateau spike phenomenon or if they're truly on a downward trend, but they entered a downward trend a little bit faster than we did starting over the weekend, it seemed. So more to come on that, but obviously we're in the zone of where we were concerned we would be. Here you can see in the rest of the outlying communities, Chemung had the big spike early on. They're still climbing again now. Certainly the US and New York State, US turned down a little bit, although there's anticipation that that's obviously going to spike as well. New York State is seeing a steady climb, and that has led to some amendment to the yellow, orange, red zone discussion that we're going to talk about a little bit more in the governor's new mitigation strategy that they've put forward. I think that's all I have for those graphics. Let's see. So a couple of things that may affect our hospitalization rates. So nursing home capacity, There are a couple of nursing homes who have had to shut down to accepting new patients because of high staff or possible facility-based spread. So that is limiting the availability of nursing home resources. We also did hear from New York State yesterday that there had been some petitions for a couple of nursing homes to be able to open COVID units where they could accept just COVID patients. The state denied that request and basically said it has to be the entire facility or none. So if there's COVID patients there, obviously they have to quarantine them, but they can't just accept COVID patients to a floor or a unit in the nursing home and that be acceptable. So that obviously limits us a little bit because that's going to impede nursing home capacity more quickly than we'd even hoped. There has been some allowance, and this is also part of the mitigation strategy, where we can do some what they're calling load balancing, where you can transfer a patient that is at the end of their hospitalization to one of the affiliate hospitals to complete their inpatient care, to at least unload some of the larger facilities. Also, they're allowing load balancing for distributing elective procedures and the like. So we'll see how much that has an effect. As any of us can attest, if we're in the hospital for 4 days and someone walks into our room and says, hey, would you be interested in being shipped 45 minutes south, east, or west to complete the next couple of days of your hospitalization? It's probably not the most exciting thing that people will bring to us. So I don't know how much assistance that's going to provide necessarily. As I said before, discharge rates are still better than they were in the first wave. So while we're seeing a significant incline in the number of patients coming into the hospitals, we are seeing an exodus, but not at the rate that we are seeing the incline in new admissions. So there's not a balance in that, unfortunately. At the U of R, and I don't know for sure at Rochester Regional, I think it's happening at Rochester Regional as well. They have started rescheduling some of the elective surgeries and procedures. They are looking to reschedule those into some of the affiliate hospitals and ambulatory surgery centers as available. There are daily meetings with the OR leadership and the senior leadership of the U of R affiliate hospitals to look at pause strategies if and when that becomes necessary. So we're having some rescheduling, not full pause at this moment, but I would anticipate if things continue on this path, we are likely to see a pause of some elective procedure types in the not so distant future. I think that's really all I have for the State of the Union discussion. So I'll slide into testing. So I know many of you have reached out. There continues to be delays in return of results from the U of R labs, especially for ambulatory patients. From all I have heard and from what the lab has confirmed, it is better than it was a week or so ago. But with the expected incline in cases, I think it is fair to expect that we are likely to see some continued delays for the foreseeable future. So two things I would say. To my knowledge, from what I continue to hear, Rochester Regional continues to have a fairly rapid turnaround time within the 18 to 24 hour window. I will say, and I've said this to others who have reached out, I believe the two institutions have taken a slightly separate strategy. The Rochester Regional ACM labs, they have started to restrict the groups that they will do testing for, whereas U of R hasn't really restricted their testing groups at this moment. So, I think it's a balancing act. As we've said before, the goal of this is really to get the testing done where it can be done most efficiently. So if it's beholden to send it to the ACM labs to get it done quicker, I don't think it's unreasonable. I anticipate that we're probably going to see delays equalizing across the community very shortly as the demand on testing gains very rapidly. But for right now, from everything I've heard and understand, I do think the turnaround time is slightly faster at Rochester Regional than it is at U of R labs currently. In-office testing update. So a couple things. I have not, as of yet, and I was actually checking my email just before I came on the webinar to see if I'd gotten any response from Roche. I'd asked for kind of a go, no go, and an absolute promise of when we could expect machines if and when we did move forward with ordering. Many of you have reached out and wanted to be included in that. So thank you for doing that. I do not, as of yet, have a hard answer from them, but I hope and anticipate that I should be getting an answer at any time now. And I've been trying to push to get that to be sooner rather than later. Still not separated from the Cepheid process, still encouraging them if they can get us machines, that would be great. Many of you have reached out with concerns about the Cepheid platform, that while, even if a machine can be available, the testing kits and cartridges are not readily available. And that for those of you that have them, you're oftentimes ordering 3 to 4 or more fold the number of cartridges that you're actually getting. So it is absolutely true that the allocation of the Cepheid testing cartridges is very limited. Unfortunately, from everything I have heard, they are putting out machines faster than they are increasing their volume of cartridge generation. So at this moment, I anticipate the availability of the Cepheid platform cartridges to be an enduring problem for the foreseeable future. To my knowledge, the Liat machine is balanced. You have trouble getting access to the machine, but once you get the machine, the cartridges are more readily available. The other hope is that if we gain access to be able to purchase machines, because they're treating AHP as a hospital/lab entity, all of you who would get those machines would be ahead of the curve of other practices who probably won't get the machines until at least second quarter of 2021. So the demand will be limited to only lab and hospital customers for those machines, and they're necessarily lower throughput platforms. So most large hospitals are not going to be primarily relying on these for their day-to-day operational needs. So that's the good and bad. I hope to have more information for you shortly about the availability of the Liats, but I don't have any other significant updates for that at the moment. The next piece I want to touch on is the billing codes for those of you who do or expect to want to have either a Cepheid or a Liat machine in your office. So we have heard the gamut of denial of codes, don't know which code, this code is not approved by this payer. I've spoken to my rep and they said they're not aware of that code. So a couple things. As we said last week, it is true that the communication that is going to all the different facets of the payers has been slow, much like anything else. Most of these codes are pretty new. So it has not trickled down, but we did get confirmation from Excelis and Misty Postal, and we have the written confirmation over email, and it will be sent out hopefully to everybody soon, that they are covering the 3 codes, which I'm going to talk about in great detail shortly, which is 87631, 87636, and 87637. My understanding is that for those of you who are doing COVID testing and to this moment have submitted the 87631, the reason you may be getting denials could be twofold. One, they don't know what the hell that code is. Two, and possibly more likely, is that the 87631 specifically says it is for flu and RSV testing. So it does not mention COVID testing in 87631. So if you say I'm doing COVID testing and submit CPT 87631, it could get denied because that's not a COVID testing code. 87636 is flu, AB, and COVID. So that would be the Liat cartridge that we would be talking about. And then 87637 is the quadruplex code where it's RSV, flu A, flu B, and COVID. That would be the Cepheid system, and that would be the appropriate code to use for that particular test. Misty confirmed that 87631, 636, and 637 are all being reimbursed currently through the Excelis system. I know a couple of you have reached out that the 87631 is reimbursing lower than the cost of the Cepheid cartridge. The Cepheid cartridge is about 65, 70 bucks. And I've heard that the 87631 may reimburse somewhere around $45. It's probably because the 87631 is flu and RSV, which is about a $20 cartridge, is my understanding. So take that for what it's worth. I am by no means a paid speaker for Excelis, MVP, or any other payer, but that's my best interpretation of the current state of the union. So we'll make sure all that continues to be updated as we learn more. But those codes are being covered, and the appropriate code for the tests that I just mentioned would be the way that I would utilize those for the moment. And I will go ahead and say, if you did have a LEAT system and for whatever reason you decided to do COVID flu and flu RSV, those would be two separate codes. That would be 87631 and 87636. That would not be the 87637. And will they deny because you ran the flu twice? I really have no idea. I don't know the answer to that. I don't think anybody knows the answer to that. So we'll cross that bridge when we get there. But at this moment, I don't think anybody has all those systems. So it's not something that we need to answer right now. But as we get closer, if that becomes reality, I'll try to get that answer for you. The next thing, thank you to Renee. There are now 4 asymptomatic testing sites sponsored by New York State that we are aware of. One is in the city of Rochester, one is in Brighton, one is in Arundecoit, one is in Genesee County and Batavia. The Genesee County Batavia is opening tomorrow. The Arundecoit opened yesterday. The Brighton opens on the 5th and the Rochester opens on the 8th, I think. Maybe I have Rochester and Brighton mixed. Okay, there you go. My Yiddish is not great. The Temple
Brith Kodesh.
Kodesh, okay, is the one that's going to open next week or on the 8th. The Arundecoit site, do you have that up in front of you, Renee? I don't have it off the top of my head.
The Arundecoit site is only open yesterday and today. Right. And pre-registration is required, and you've got to register for that by 3 o'clock. So we're probably not going to. I'm not going to share information about Arundecoit in today's email, since that ship will have sailed.
Right. And then the Rochester site, I don't remember where that one was. That East High? East High, yeah. Okay. So that one will be open as of the 5th, and so those, as far as we know, the Rochester and Brighton sites will be enduring. The Genesee County site is only open for now. I don't think that's supposed to be an enduring site either. And the Arundecoit site will cease to exist this afternoon. So just to be aware that those are the asymptomatic additional testing sites other than MCC that we are aware of. Now on
There's
to
a question about PCR or antigen tests at these locations. My understanding is that the Genesee County is at the rapid test. The others, I don't think they're indicating what test it is.
Yeah, I don't know the answer to that either. I've not seen it. LJ, do you know?
I believe it's antigen, but we can double check on that because it's asymptomatic testing. We can double check on that because MCC's testing is in fact PCR. So just thinking, I don't know that they got a whole slew of new PCR tests. I'm thinking it's probably antigen.
I can confirm that I think it's the Abbott Binex now that they're using for the schools.
That's what
that are at these other sites. I'm pretty sure, but I don't want to lie about that.
There's a question, yeah.
So I actually don't know where they register for those sites. I think they have to go to the links that were put out for those sites. Do you know, Renee?
So there's no registration required for the Monroe County one. So the Rochester East High School and the Brighton one. Like, Arundecoit is pretty much over, so you can take that really off the list. Right. And actually, it does say self-administered COVID-19 rapid tests.
That's right.
Is what will be, so at all locations then, Genesee County, Rochester, East High School location, Brighton, Temple, Brith, Kodesh.
Perfect. Okay, there you go. So no registration necessary, but it is antigen testing, so that's good, or good to know. All right, so now on to the new mitigation strategy. So just at the time, oh yes, please.
No, there's just one last question, which is these are for all people, not just school-related asymptomatic testing.
All people, yes. And in fact, I would say the school-related testing is being done through the school, so probably would not send the kids there because it would not count to the school's testing requirements that they're having to attend to. So just as everyone was feeling so warm and fuzzy after last week of our beautiful explanation of yellow, orange, red, it's changed. So enjoy that. So everything we shared last week, you can throw away and never look at again. So the governor's new New York State mitigation strategy still has yellow, orange, and red. But for those who are enjoying colors, it's not really a color. We've also added an emergency stop feature, which makes it sound much more exciting. So yellow, orange, red are pretty much exactly what we shared with you last week, but there is now the addendum of hospital and staffing and I believe there may even be some resource allocation like PPE factors that will be added to it. I have not seen the hospital metrics that will be added. They've said they'll be coming out in the next couple of days. I have not seen it as of yet, and I tried to look briefly this morning and haven't seen it come out. But generally, the yellow, orange, red, as far as the community rolling average over 7 days, all that stays the same. But there are new capacity standards for hospitals in those regions that will be added to this as well. The emergency stop feature is if a hospital suddenly reaches a plateau as far as available capacity, then everything can go immediately to red and be put on pause based on the hospital capacity issue alone. Because that's the biggest concern at this moment, is that we're going to exhaust hospital capacity quickly. The other potential benefit is that the governor and health department at the state have heard and agree that schools are not where the spread is occurring. So K through 8 schools can continue to exist in live classes as long as they continue to adhere to a testing strategy. So if you're in the orange zone, 20% of on-campus students, faculty, and staff must be tested per week. If you go to a red zone, then 30% of students, faculty, and staff have to be tested per week. That is on campus. If somebody refuses testing, then they must go remote, and they don't count towards the on-campus denominator. And that testing will all be antigen-based testing, reflexing to PCR if it is positive, although there has been some discussion, I believe, and LJ can correct me if I'm wrong, that because of our net rolling positivity, there's been some discussion of whether the antigen test may count in and of itself for the school-based testing. Yes.
Are you waiting for me to jump in there?
I am.
I'm waiting for a response, and then I'll have that for tonight for the PCP advisory group. That's not been confirmed yet,
Yeah.
but we've been asking that question.
Yeah, I heard
the
that
rising prevalence.
But I haven't heard it blessed from on high yet. So those are the new stipulations of the New York State mitigation strategy. The other factors, which are not part of the criteria, but new things that have been reinforced, the hospitals have to have a 50% surge capacity option that they have to present and have ready at any time. That can include this load balancing where they can distribute patients across the entire network of associate facilities. So a la, even if Strong were operating at 110% capacity, but they could unload to Noyes and Jones and St. James who have available capacity, that would still count in this load balancing plan. Number 2, each region must have an emergency field hospital staffing plan available. Doesn't mean they have to have the staffing readily sitting in the parking lot waiting. It doesn't mean the field hospital has to be up, but they have to have the staffing plan ready to go. So that's going on as we speak as well. The other thing that got emphasized from the governor is that most of the spread is happening in small group gatherings. And it is increasingly difficult for the state or any law enforcement agency to legislate or enforce those. It's education and citizen participation. So unfortunately, it's the parties and the get-togethers and the small group gatherings that still are putting us at risk at the moment. And that may not be adequately addressed by any governmental strategy at this moment. So that's the reality of the game. Moving on, I'm going to talk about vaccination for a moment. Also a popular topic amongst folks. So for those who heard yesterday, the CDC vaccination work group has put forth the final recommendation that the first groups who should receive the vaccination will be frontline healthcare workers and residents of nursing homes. U of R does know that they have been identified as one of the first distribution sites they will receive vaccine. What we don't know is, while we've talked about, there are 3 vaccine candidates, the Moderna, the Pfizer, and the AstraZeneca. The AstraZeneca is almost certainly not going to be approved in the US in the short term. And in fact, AstraZeneca has already started another trial because of the concern between their 62% and 90% efficacy that they saw in the 2 trials that they ran. And I think they're going to have to answer that question before the FDA is going to give them emergency use authorization. So they've already started that. They have not filed an emergency use application with the FDA at this moment, so they will not be a candidate for this first wave of vaccine plans. Our vaccine distribution depends very heavily on which vaccine we get. So both Pfizer and Moderna have put forward their emergency use authorization. They went out within days of one another. It's likely they will both get approved about the same time. The European Union just approved, or the UK, I should say, just approved the Pfizer vaccine for distribution and use in the UK as of yesterday. So if we get the Moderna vaccine that has to be stored at the ridiculously low temperature, that's going to affect where the administration can occur. If it is the Pfizer vaccine that's a little bit more shelf stable, a little bit more standard refrigeration, that allows it to be distributed and administered in a little bit more of locale. We don't know the answer to that yet. So that will hopefully unfold over the course of the coming days. The anticipation is that the FDA will make its determination about the EUAs for both companies likely by mid-December, and that by end of December, we'll probably be seeing needles in arms. So a lot's going to happen here in the next 14 days, probably, as all of this information starts to unfold. As of today, the U of R has already started collecting information amongst its employed staff from department heads as to who is forward-facing and most front lines, so who is a hospitalist, ICU attendant, likely to come in with COVID-infected individuals, ranking all the way down to administrative staff who will likely have no direct patient contact. So they're trying to organize the employee list. I would say it's probably not unreasonable internally for your practices to do the same. So who is likely to have forward-facing exposure? Hospital exposure will be considered a higher risk than ambulatory exposure. So if you have providers who are going into the hospitals to see patients, they would go to the front of the line before staff who are seeing ambulatory patients alone. Likewise, if you have backroom clerical workers who are doing phone calls, they would fall to the bottom of that list. So it may not be unreasonable to go ahead and start queuing that up just based upon the fact we don't know how much vaccine will come available and when. So that's all I know right now. I wish I had more, but that's where we're at. The next thing I want to talk about is PPE. So PPE, we're starting to see some shortages, most pressingly in nitrile gloves. So nitrile gloves are a difficult one in that the raw materials are made very scarcely and take somewhere on the order of like 12 months to even produce the raw materials so that you can begin to make the glove. So the difficult thing is we're a year away, even if other agencies start to produce nitrile gloves, we're a year away from gloves actually making it onto shelves. So this is not one that we can fix very quickly. Because of this, and even before, vinyl gloves have been approved by the CDC as an equivalent alternative to nitrile gloves. We've only been distributing nitrile gloves ourselves from AHP to this point. While we have kept, when I say we, I say us and the U of R supply chain, has kept a pretty good amount of nitrile gloves on hand, we're going to exhaust that pretty rapidly because the supply is diminishing pretty quickly. So what I would ask all of you is to give some consideration to where in your practices you could get by with using vinyl gloves alone, because we're likely to start splitting our supply between those two. My recommendation, as you start to give it consideration, is that the nitrile gloves could be used by front-end staff who's rooming patients. So if you have MAs who are doing blood pressures and med list reviews who are wearing gloves, vinyl gloves should be sufficient. If you have routine physical, Siri doesn't like that answer. If you have routine physical exams in asymptomatic, non-infected individuals, vinyl gloves likely are sufficient, or no gloves at all, and just washing your hands after each contact. If you're doing COVID testing on symptomatic individuals, I would probably recommend the nitrile gloves for right now. Again, vinyl gloves are considered an equivalent alternative, but we are not to a point where we say we only have access to vinyl gloves. So I would say for now, reserve your nitrile gloves for the sickest and highest risk contacts, and probably use vinyl gloves if the rest of the time. Nothing else to say about that. N95s are in slightly slower availability, but we still have adequate supply. So I'm not seeing any pressing concern, but it's just something we're continuing to keep an eye on as the supply chain's getting more taxed as there's more people who are testing and coming into contact with COVID positive individuals. So hospital usage and all that is going up, which means the supply chain gets more stretched. But right now we're still doing fairly well with N95 availability. Otherwise, we're doing great from a PPE standpoint and no other issues for the moment. Final things are just updates. So number one, there was for those of you who have not received it, there's a New York State telehealth survey that promises to be a 20-minute SurveyMonkey questionnaire, which I'm sure is what everybody is dying to do more than anything in the world. However, they are planning to use this for the state's recommendations for telehealth and coverage on the back end of COVID. So I do think it's probably worth the time to answer the questions, because it probably will have some implications about what the state Medicaid program will be recommending and approving for telehealth usage. So we'll put that link in our email that'll go out today. Number two, the PEDS PCP advisory meeting is tonight. As LJ indicated, there's going to be all kinds of fun things to talk about. So it's probably a good one to attend. So that is useful. The other thing is, since kind of the world is on fire right now, we talked and we thought it's probably wise to increase the frequency of these webinars, because the information is coming pretty fast and furious for now. So what we've talked about is going back to adding Mondays to our webinar schedule. So we'll do Mondays at 12:15 and Wednesdays at 12:15. I realize that's kind of weird, but I know people have already kind of blocked out the Wednesday time frame, so we didn't want to ruin that. And Fridays, nobody seems to like, so we decided we go to Monday, Wednesday for now. And that way we could push out information a little bit more quickly to keep everybody abreast on what's going on. Behavioral health webinars will still remain on Tuesdays, so you can join us for Monday, Tuesday, and Wednesday and get your lunchtime fix of your AHP friends and family. And then our PPE survey either has or will be going out shortly for the pickup that will be on December 9th for the next pickup. Whew. And we still have 7 minutes to spare. Renee or LJ, anything you'd like to add? No and no. Okay. So we can open it up. I see there's 14 things in the chat room that I probably glanced over and didn't address at all. So LJ, do you have things that you've been watching that need to be addressed?
There was a question, I think you addressed this, but specifically around the vaccine. Once we know the amount of vaccine that's coming available and what the distribution plan is AHP working on a way to get the vaccine to private providers or staff? So
yeah,
that
so
was
so it is a conversation. I think the big issue, if this thing has to be stored at minus 70 degrees, none of us have that kind of capability. I mean, it's going to be kind of a research entity that can do that. So if we get the Moderna vaccine, it's going to be tough to get it distributed widely. If we get the Pfizer vaccine, or if we get some blended amount of both, I suspect it's going to go through the hospitals first. Whether it will come to community ambulatory practices, I really suspect is going to be determined by the volume of vaccine that we get. I anticipate that we probably will not have enough vaccine to even vaccinate all frontline and nursing home patients. Understanding that there'll be a good number of those who refuse. So there's a lot of variables in the air on this. Which vaccine we're going to get, what volume of vaccine, how many people will refuse, what's the storage requirements. So there's a lot of things we have to figure out between here and there.
Yeah, Chad, I think the question on that one is really about, sort of advocacy for primary care providers who are not URMC employed.
Oh, yeah.
And their staff who are frontline.
Yes. So we've actually already had that conversation.
Yes.
Everyone's going to be treated as equal. There will be no delineation between you are employed or community. Everybody gets the same access based on need. So yes.
Excellent.
We won that. Well, it wasn't really a battle. Everybody just agreed. So that was good.
I'm screening through the questions to see.
I know, I'm sorry. My reading.
No, it's okay. There was a question about reimbursement of telehealth moving forward. Is there, I mean, it's open-ended at this point right now. We're in a pandemic, right? So there's no question about.
The emergency, state of emergency will continue to be, at least right now, it gets pushed out 30 days, pretty much on the 29th and a half day by the governor. So as long as that state of emergency continues to exist, they will continue to provide pandemic level coverage as it has existed to date. We've already got guarantee that everything will remain the same through the end of the year. We have pushed, pulled, requested, begged that they tell us as soon as possible what their long-term intentions will be, understanding that at least for the Medicaid lines of business and others, the local payers don't have infinite control over those decisions, but at least for the commercial contracts, they can tell us what the coverage rate will likely be. So we're still waiting for those, but I don't think we're going to see any change for the foreseeable future. And in fact, I anticipate the U of R is already making plans to go to more telehealth visits. So I anticipate we're going to see a higher use of telehealth for all of us here as the infection rates go higher.
Yeah. Then there's a comment about the opportunity for more public health messaging around what quarantine actually means when you've been exposed, when you've really been exposed as a close contact, and that people are rushing to get asymptomatic testing, thinking that that gets them out of quarantine. We really do need to get that message across. It's been very confusing, I think, because of the whole travel guidance and the fact that you could test out of quarantine around travel. It is completely different if it's a close contact exposure. So I agree with the comment there that we need to do a better job. We need to be able to articulate that to our patients, but as in terms of public service messaging, that's got to come through loud and clear. And we will continue to elevate that concern to the county health department and to the county executive.
And I will say the CDC did help a little bit in this regard, help hurt, you decide. So I think it was yesterday, they put out the recommendation that if you had a close contact, so you're within 6 feet with one of you without a mask, you had more than 15 minutes worth of exposure in a 24-hour period, that you are considered a primary COVID contact of a COVID infected individual, that you should quarantine for 14 days if asymptomatic. You can quarantine for 10 days if you're asymptomatic for that entire window, or you can quarantine for 7 days if asymptomatic and a negative COVID test. So that just came from CDC. The 10-day quarantine for asymptomatic individuals, there was a 1% chance of spread of the virus if you had a primary COVID contact. The 7-day with negative test had a 5% rate of transmission. 5% sounds like a high number to me. I don't love it, but they also don't pay me to run the CDC, nor do they probably intend to do that anytime soon. So those are the current recommendations that the CDC just released yesterday.
Thanks, Chad. And then I think there's a last message. There was a question about whether the urgent care centers, specifically acute care kids, was doing rapid testing for symptomatic or asymptomatic kids. Just a reminder, asymptomatic testing is not covered by insurance. And so, and because of needing to prioritize supply, acute care kids has noted here that they're reserving their rapid testing for symptomatic patients. The urgent cares through UR are not doing any asymptomatic testing at this point. Those are all being sent, referred out either through schools, through these other community sites, through MCC. If you do asymptomatic screening, patients will have some form of cost share in that, or all costs, not even cost share, right? They'll incur all costs from that. I think that's all of the, I might have missed something else in the chat, but I think I scrolled through pretty fast there, Chad.
Perfect. All right. Any other questions that folks have, or amendments to anything that I said that was a lie? I'll just say an unknown untruth. All right. Well, guys, it is 12:59. We will give you 1 minute of your life back, and we will see you guys back here on Monday and for our next installment, or we'll certainly reach out if there are other issues that come sooner.
Thank
Hey,
you.
Chad. Genesis Pizza is asking, how young does MCC test? They test all the way down to infants now. They did not used to, but they do now.
There you go.
That's it.
Last second entry. All right, guys. Have a wonderful rest of the week. See you on
Bye.
Monday.
Thank you.
Bye-bye.